You are going to do this lots of time. Have a look at soft palate. Okay? If you touch anything of the pharynx, the patient will what? Will gag. Gag is a reflex. Afferent to efferent. Okay? And this gag should work very well. If it works very well, it tells us that the lower part of the brain stem is working. The nuclei of Glossopharyngeal, which is the afferent, and the vagus, which is the efferent. And we test that. If things are not all right, then once you open the mouth of this patient, you can see that the uvula is deviated to the good side, because it should be in the center. This is deviating to the right because the left is not working. That means the connections are not all right. The glossopharyngeal nerve provides sensory supply to the palate. Is the palate important? Should I care about the palate? The answer is yes. The palate regulates the function of the oropharynx and the nasopharynx. If things are not all right, then the patient can inhale saliva or inhale food, resulting into severe, maybe fatal chest infection. So function of the palate is very important. What's the sensory supply and what is the motor supply? The sensory supply comes from the glossopharyngeal nerve. How do we test it? We test it with gag reflex. Quiet, please. Or you touch the arches of the pharynx. You know what the arches of the pharynx are. The palatoglossus and palatopharyngeus. This is telling us a rough idea about the glossopharyngeal nerve. This image is telling me that, look, there are two ganglia. Okay. And where do you think this branch is going? Soft palate and tongue, right? And where are these branches going? To the pharynx. Here is the start of the story. Where are we? Lower part of the medulla, and this structure is telling me that this is the olivary nucleus, this is the pyramids, and I can see these two long nuclei in the brainstem. This is the nucleus of tractus solitarius, and this is the nucleus of trigeminal. That's the olivary nucleus. This is nucleus ambiguous, the motor nucleus that gives input to glossopharyngeal, vagus, and accessory. And this is the parasympathetic motor supplying salivary glands and glands of the head and neck. Inferior salivatory nucleus. The superior one belongs to the facial nerve. This is nucleus and tractus solitarius, and this is the trigeminal nucleus. Input if there is an input to this area, which is going to the trigeminal nucleus, then this should be what? Sensory, right? If this input, okay, and this is an output, and this is an output. So we have 3 inputs, 3 sensory and 2 output. Story number 1, parasympathetic motor, meaning going to glands. Inferior salivatory nucleus. Fibers exit through the glossopharyngeal nerve. Foramen, jugular foramen. Now, why is this triangle coming in? Because the motor supply going out is not related to the ganglia. Glossopharyngeal nerve has 2 ganglia. Fibers go out of the inferior salivatory nucleus, re-enters the skull to the tympanic cavity, making a plexus. From the plexus, lesser petrosal nerve goes out of the middle ear, enters the middle cranial fossa, comes out of the skull again through foramen ovale to mandibular division of trigeminal, reaching the otic ganglia. And you know the story of the auriculotemporal nerve reaching the parotid. So the glossopharyngeal nerve, its parasympathetic part goes to the parotid gland. Story number 2, nucleus ambiguous. It's motor. Fibers come out and they go to styloid process, which is very near the jugular foramen, turns around it and supplies the stylopharyngeus muscle. The glossopharyngeal nerve supplies one single muscle, the stylopharyngeus. It's one of the perpendicular muscles of the pharynx. It pulls the pharynx up. Little story again. Now it's general sensory. Upper pharynx, posterior 1/3 of the tongue. They receive fibers from the glossopharyngeal and through the pharyngeal branches, and they come into the glossopharyngeal, and the cell body as a sensory must be outside the brain. Therefore, the glossopharyngeal nerve has 2 ganglia, okay, outside the brain, at the jugular foramen. And the axon will go, of course, if it is general sensory, then it is going to end in the trigeminal ganglia. Carotid sinus, a dilatation either at the end of the common carotid or at the beginning of internal carotid, senses blood pressure, baroreceptors. And then the carotid body, a little mass of special receptor cells near the bifurcation, senses chemistry. These impulses, sensory impulses, they collect and form sinus nerve. Sinus nerve is a nerve telling us what is going in the internal environment of our body. So its destination must be the nucleus that collects information and regulates our internal organs, which is the nucleus and tractus solitarius. So these information have their cell bodies in the inferior ganglia, and then fibers will go and end up in nucleus and tractus solitarius. Other story, posterior 1/3 of the tongue. Taste sensation, special taste sensation. Where is this sensation going? Of course, it goes to what regulates the internal environment, اللي هي nucleus and tractus solitarius. Okay, through pharyngeal branches, okay, and goes to the upper part of nucleus and tractus solitarius, which is called the gustatory part of this nucleus. This is the glossopharyngeal nerve going towards the jugular foramen. Here's the jugular foramen. You can see the jugular vein, start of the jugular vein. This is part of sigmoid sinus. The jugular vein starts here. The jugular foramen has a special compartment for nerves. And this is the glossopharyngeal nerve. There's a branch that comes out of it into the petrous part of the temporal bone. This is the jugular foramen. This is the petrous part of the temporal bone, and this is the middle cranial fossa. Glossopharyngeal nerve gives a branch that enters the petrous part of the temporal bone, and we have seen that in case of the middle ear. This is the tympanic nerve. Makes a plexus on promontory of the cochlea, and the tympanic plexus will give lesser petrosal nerve. Into the middle cranial fossa, passes through foramen ovale, and then to the mandibular division of trigeminal, synapses in the otic ganglia, and goes to the auriculotemporal nerve, the nerve with two roots with the middle meningeal artery in between, and reaches the parotid gland. That's the parasympathetic part of the glossopharyngeal. Here's the story collected in this image. Here's the superior ganglia at the jugular foramen. And this is the inferior ganglia at the jugular foramen. Once it comes out of the jugular foramen, this glossopharyngeal nerve is related to this process, styloid process. Turns around it and supplies this muscle. This muscle is the stylopharyngeus. This nerve is going to supply one muscle, and it is the stylopharyngeus muscle. Okay? Now, it continues towards the posterior 1/3 of the tongue and supplies common sensation and taste. Then, what is the rest of the nerve is going to give nerve supply, sensory, to the pharynx and the pharyngeal plexus. The other story is starting here, carotid body and carotid sinus. The information is collected and passes through what is called sinus nerve. This is the stylopharyngeal muscle. The glossopharyngeal nerve is a regulator of blood pressure. Tells the brain what's happening in the blood pressure. Here is the stylo. This is the stylopharyngeal muscle. Perpendicular muscle. This arrow shows that the pharyngeal branches, they come and enter the pharynx. This is posterior view, giving sensory supply to the plexus. This is the stylopharyngeal muscle, and this is the glossopharyngeal nerve, and supplying it. This is the glossopharyngeal nerve. Now, the gag reflex. You touch the pharynx, upper part of the pharynx or the soft palate. Sensory input, when بيروح, it goes to the trigeminal nucleus. The trigeminal nucleus is going to send collaterals to the nucleus ambiguous. The nucleus ambiguous is going to send collaterals to the motor of trigeminal. The motor of trigeminal goes to V3, mandibular, open the jaw. Then fibers will go to the hypoglossal nucleus, thrusting the tongue. tongue بيطلع على برا. And the nucleus ambiguous will send fibers to the vagus for contraction of the pharyngeal constrictors. So that's the story of the glossopharyngeal. The vagus. This lady opened her mouth, the uvula is remarkably deviated to the right. The left is not working. The left muscles of the soft palate, which are supplied by the vagus. Remember, the glossopharyngeal is sensory, is the afferent. The efferent is the vagus. And we have seen this patient just a few moments ago. This is the normal thing. You are going to do this lots of times. Lots of times. The uvula is in the center, everything is balanced. This lady is showing that there is a problem when she swallows, the swallowing is not right. Okay? Problem in the pharynx and esophagus. This lady is also having a problem in swallowing. So what's happening? Let's see the story. The story begins with the vagus nerve. It is the longest cranial nerve. It has motor part and sensory part. Sensory part is much more than the motor. It passes through the neck and thorax and abdomen. No other cranial nerve goes out of the head and neck except the vagus. has the widest distribution. Lower part of the medulla, the collection of trigeminal nucleus of tractus solitarius, the nucleus ambiguous. Central connections are, this is the parasympathetic motor nucleus of the vagus. This is nucleus ambiguous for skeletal muscle contraction. And nucleus of tractus solitarius for collecting information, sensory, collecting information from the internal environment of the body. And there is this part, parasympathetic, connected to the nucleus ambiguous. Strange thing to happen, and this part is concerned with the heart. Parasympathetic fibers to the heart. Amazing. Strange. There's this little story. This is parasympathetic motor nucleus. Dorsal vagal motor nucleus. It's parasympathetic, sends preganglionic parasympathetic fibers and goes to the parasympathetic ganglia in the thorax and abdomen. The other story of nucleus ambiguous for skeletal muscle. Motor fibers, they go to the muscles of the palate, pharynx, larynx. When it goes to the palate, check if the patient has إيش لما البالate is not working. شو بيعمل؟ يعمل nasal speech، يعني الواحد يحكي من أنفه. شلونك؟ يحكي من أنفه. Okay. Pharynx, is there any problem with swallowing? Larynx, voice. Therefore, we have to test voice, swallowing, and gag reflex. If the vagus is going to supply muscles of the soft palate and pharynx and larynx, especially if it was on both sides, then swallowing is going to be completely disappearing. So ما يقدر يعيش غير ما ياكل. Respiratory problems. The coordinator between respiratory passages and upper GI passages is the soft palate. Saliva or things will get into the respiratory system, resulting into severe respiratory problems. Normal speech could be lost forever because it supplies the larynx. It's a dangerous situation. The story of nucleus and tractus solitarius, the center that collects information from the body. Visceral sensory fibers from the pharynx, larynx, trachea, esophagus, thoracic and abdominal organs, plus taste buds from the epiglottis. The nucleus of tractus solitarius, the parasympathetic motor nucleus, nucleus ambiguous, and trigeminal nucleus. They receive the sensory input through the vagus, must have their cell bodies outside the brain. Therefore, the vagus has two ganglia at the jugular foramen. The visceral sensory will go where? Nucleus of and tractus solitarius. Okay. The general sensory synapse in the superior ganglia. Where are they going? Trigeminal nucleus. Parasympathetic, from where are they coming? They are coming from the dorsal motor nucleus. Efferent to skeletal muscles. From where are they coming? Of course, nucleus ambiguous. The somatosensory, from the dura, from the pinna of the ear, outer ear canal. They are somatosensory, and they will end up, of course, in the trigeminal nucleus, because they are skin sensations, somatosensory. This is how the vagus comes out of the brain. Jugular foramen. You see the jugular foramen here? There is some sort of division into two compartments. This is the jugular foramen, the compartment that contains nerves of the jugular foramen. And at the jugular foramen there are two ganglia. Superior ganglia will give a dural branch to supply the dura, meningeal branch, and it gives branch to the auricular area. That's why we say don't overstimulate auricular branch of the vagus, because it ends up stimulating the nuclei and the heart could stop. That's the meningeal branch and auricular branch. This is the vagus running in the carotid sheath. It is crossing the subclavian artery anteriorly. This kind of relation differentiates it from the phrenic nerve. Now, students and doctors, they find difficulty sometimes distinguishing the vagus from the phrenic. The vagus is the most medial, the phrenic is lateral, and the vagus crosses the subclavian artery. That's the sympathetic trunk, easy to recognize. Vagus nerve, when the carotid sheath is opened, this structure in front of this pointer is the common carotid. That's the jugular vein. This is the vagus nerve. The vagus nerve is posterior to these vessels and lateral. This is the mandible, this is the angle of the mandible, this is the ear. This is what? Larynx. Sternomastoid has been removed. The carotid sheath is opened. Therefore, we can see the common carotid, jugular vein, internal jugular vein, and we pull the vagus from posterior of these structures. That's the vagus. The vagus. That's the posterior view of the pharynx, just below the base of the skull. This is the vagus. Here is something interesting. Now, scientists has discovered that if they put a pacemaker like that used in the heart, and they apply it to the vagus in epileptic patients. Now, epileptic patients, they get better, and they have more free space between fits, and shorter fits and less violent fits. So stimulation of the vagus helps epileptic patients. Branches in the neck, superior laryngeal nerve, recurrent laryngeal nerve, pharyngeal branches, and cardiac nerves. Where are we? That's the mandible, and this is the larynx. This is the vagus nerve, dissected very cleanly. This is the division point, and this nerve comes out. It is the superior laryngeal nerve. Superior laryngeal nerve divides again into internal laryngeal and external laryngeal. Vagus, superior laryngeal. Vagus, superior laryngeal. That's the superior laryngeal. Internal laryngeal is going to pass to the inside of the larynx through a hole of the thyroid membrane, and the external laryngeal stays on the outside. This is the gag reflex. This is a posterior view of the pharynx, showing all these yellow lines. The pharyngeal plexus. Now, the glossopharyngeal supplies sensory element to this, and the vagus supplies the motor. If there is no sensory supply and there's a problem with the vagus, the uvula is going to deviate. So the gag reflex starts with touch the pharynx, touch the area supplied by the glossopharyngeal. Cell bodies in the superior ganglia, of course, is going to end in the trigeminal ganglia. Trigeminal ganglia is sending fibers to the solitary tract nucleus, and nucleus ambiguous. Nucleus ambiguous sends fibers to motor nucleus of trigeminal to open the jaw, sends fibers to the hypoglossal nerve to protrude the tongue, and the vagus to contract the pharyngeal constrictors. So gag reflex involves 9, 5, 12, and 10. It's a good test of the lower segment of the brain stem. Sensory component, 9th. Motor component, 10th. Plus mandibular of motor of mandibular plus hypoglossal. Good test for lower part of brainstem. This is something we have already went through. Pharyngeal branches from the inferior ganglia, they are sensory and motor. The motor of the vagus, they come from the accessory nerve. Little confusing fact. The motor will go to the pharyngeal plexus, and the pharyngeal muscles will contract. If you have no nerve supply to the pharyngeal muscles, then the patient will have bad swallowing. That is a big problem chest infection, dangerous problem, and you have to feed the patient through a nasogastric tube. Put the food into the fan. Swallowing is bad. If it's bad, food or drinks will get into the chest and creating serious problems. This is how extensive the vagus nerve in the neck enters the thorax and gives recurrent laryngeal nerve. The left turns around the arch of the aorta. The right one turns around subclavian artery, supplying recurrent laryngeal nerve, supplies muscles of the larynx. If it is cut, the vocal cord will be paralyzed. Okay. Hoarseness of the voice. This is the midline. The red one is bad because it is not abducted. It should be abducted. Yeah, this one should be like this one. That's the left vagus and this is the right vagus. This nerve here is the phrenic. The two vagi enter the thorax and make an esophageal plexus. And lower down they become anterior vagus and a posterior vagus. So they come as a nerve, they make a plexus and then they make a nerve again. In the thorax, now we cough because we feel something is irritating our respiratory system. This sensation is coming through the vagus. And it is important. If we don't feel that there's something wrong, we don't cough. So the secretions will accumulate. Okay? No cough is serious. Why? Because of retention of secretions and foreign bodies. We should ask the patient, do you cough when we test the vagus nerve? The sensory component is the vagus. The center is the medulla. The motor component is expiratory muscles. The most important one is what? The diaphragm. The vagus nerve also senses chemistry and pressure of blood, not from the carotid body and sinus, but from the aorta, okay, called aortic bodies. Chemoreceptors at the aorta through the vagus nerve. So the vagus nerve also controls blood pressure. Well, we can conclude that the glossopharyngeal and the vagus, they work together in regulating the soft palate, in regulating deglutition, swallowing, in regulating blood pressure. They work together. Superior cardiac nerves, two branches, they communicate with the sympathetic. Lower end of the esophagus and anterior esophageal plexus. Left vagus crosses the diaphragm, supply the stomach. Therefore, when we test the vagus nerve, we ask about acidity. Do you have acidity coming back? Do you have problem with the stomach? And it supplies the small and 2/3 of the transverse column. Therefore, when we test the vagus nerve, we ask the patient, how is your bowel motion? The vagus nerve is in the neck, thorax, and abdomen. And the neck supplies the soft palate, the pharynx, and the larynx. And we ask the patient these questions. In the thorax, we ask about the heart rate, lungs, its motor for the glands and smooth muscles, plus sensory. In the abdomen, it is motor to glands, smooth muscles, plus sensory. This is how we ask our patients. Say ah, to elevate the soft palate. Check the voice. Check gag reflex. Ask about swallowing. Ask about cough. Check pulse. Ask about stomach acidity and bowel motion. Okay? This is a repetition. So that's the vagus nerve. Accessory. This beauty is combing her hair, but how can she do that? She has to elevate and rotate the scapula, which is the action of trapezius. Okay? This lady, this is the surface anatomy of the trapezius. You can't see any. Very atrophied trapezius. This patient has different levels of the shoulder joint. This looks normal, and this looks sagging down, coming down. That's loss of function of trapezius. This young kid has his head stuck like this. No nerve supply to the sternomastoid. For some time, the sternomastoid will go into atrophy and fibrosis, pulls the head this way because of loss of nerve supply to the right sternomastoid. Same situation. So what is the story here? It's the accessory nerve. The accessory nerve has cervical part and cranial part. Special, no other cranial nerve has this. And this is the brain stem, and the story starts here. When I say here, it's the lower part of nucleus ambiguous. Taking the lowest part of the share with the vagus and glossopharyngeal. Where is the accessory? Parts coming from the spinal cord, plus the cranial part. It's a tiny nerve. Here's the nucleus ambiguous. Lower part belongs to the accessory nerve. Added to it, lower 4 or 5 spinal cord rootlets. So the cranial part plus the spinal part, they make the accessory nerve. And goes out of the skull. But look at these fibers. Fibers from the accessory they join the vagus. These fibers, they go to the soft palate, larynx and pharynx. So what moves the soft palate, larynx and pharynx To start with, it belongs to the lower part of the nucleus ambiguous to the accessory. And they travel with the accessory for a short distance and then they jump to the vagus. The spinal part of the accessory goes down C1 to C5 or C4. They enter through the jugular foramen. They enter through the jugular foramen and then they go out. These are the two parts of the accessory nerve. The accessory nerve, when it comes out, it travels in the posterior triangle of the neck. Now, there is this lymph node which is favorable for biopsy. Cases of lymphomas, leukemias, Hodgkin's, and people like to take it out. This is the scalene lymph node. Now, if they are not careful, like in this case, the accessory nerve is just deep to it. Okay? That's the accessory nerve deep to trapezius. And this is the accessory nerve in the posterior triangle. Cut it, the shoulder will drop. Test, ask the patient to shrug his shoulder against resistance or turn the head against resistance. This lady doctor is feeling the sternomastoid and ask him to shrug the shoulders. لا أنت when you want to test this when it contracts, okay, it brings your ear towards the tip of the shoulder. This is relaxed. لا أنت you put your hand, say press against it. Ask the patient, protrude the tongue goes to the left. The right is working, especially the genioglossus, the right one. The left one is not working. If it works, it brings the tongue in the middle. So there's a problem with nerve supply. This tongue is in the center. This tongue is pointing to the right, and you can see that the right is atrophied, okay, normal and paralyzed, deviated tongue. Why should this happen? It's the hypoglossal nerve. What's the story of hypoglossal nerve? Story starts at the motor nucleus. Hypoglossal nerve is purely motor. It's on the dorsal side, just off the midline. Axons cross the brain stem, the lowest part. Here is olivary nucleus and here is the pyramid, and comes out as rootlets. Comes out through the hypoglossal canal. Forget about the jugular foramen. Several nerves went through the jugular foramen. There are 9th, 10th, and 11th. Okay? But it enters carotid sheath. Very shortly comes out and crosses the internal carotid, external carotid, and loops around the posterior the occipital artery. This is the olivary nucleus. This is the pyramidal system, and it comes between them. Here is the the hypoglossal nerve. The story of where is the hypoglossal nerve? It is in the submandibular region. It has a connection with, that's the hypoglossal nerve. And this is what is called ansa cervicalis. This is the hypoglossal nerve. It is crossing loops around occipital artery, crossing external carotid, crossing facial artery. Superficial to hyoglossus and deep to mylohyoid. This is the hypoglossal. The posterior belly of digastric should be removed so that we can see it. Angle of the mandible. This is the submandibular region. Two people quarreling with each other. One took a knife and a wound here. Okay? You expose the area and it is trauma to the hypoglossal nerve. Okay? That's inside the mouth. Okay. Story of ansa cervicalis is, this is hypoglossal nerve. Okay. C1 will attach itself to the hypoglossal nerve, going to the muscles of the anterior part of the neck, and coming down, descending hypoglossa. It has nothing to do with the hypoglossal. Hypoglossal goes to intrinsic and extrinsic muscles of the tongue. Okay, C2 plus C3 descending cervical part, and they meet. They make a circle called ansa cervicalis. Thank you.